Hi, everyone. Welcome to Ortho Rehab's first web-based presentation. I'm here to talk about concussion tonight. My name's Tracie. I know we have some people from around the state, around town in Kalispell, and maybe even out of the state. So I just want to welcome you to my little talk about concussions. Just a couple things. There is going to be a question and answer session after the presentation, but you can also ask some questions during, and I have Tyler here that's going to relay some questions to me as we go along. If you're on a computer, there should be a little box that you can click on to ask the question. You can type your name in or ask anonymously if you have something weird to ask. And also, if you're on your cell phone, just tap your phone and there'll be a little box that comes up with a little question mark inside. Please feel free to ask questions as we go along. There's no question that's too simple. There might be some that are too hard that I can't answer, but I'll do my best, or I'll just say, I'll look that up. But thanks for joining, and we'll get started. So today I'm going to talk a little bit about the myths of concussion. As I've worked with patients, I think there's a lot of misinformation out there, a lot of misinformation from the media, sometimes even practitioners like myself or physicians that might give the wrong information to the patient. And that can really influence. The other thing I'm talking about today is the management of concussions. How are we treating our athletes, trying to get them back into play and manage their schoolwork and their day-to-day life or their work life if they're older athletes. So hopefully I can kind of dispel some myths tonight and talk just about how we might manage concussions a little better. So like I said, my name is Tracie. I am the Ortho Rehab Evergreen Clinic Director here in Kalispell, Montana. I'm a physical therapist, also a certified athletic trainer, and just some interesting concussion as I've gone along. When I started out as an athletic trainer, we weren't really talking a whole lot about concussion. And so even in the last few years, I've really gotten more interest and spent some time learning about concussion. Some of that stems from my training as a vestibular rehabilitation specialist. I went through the American Physical Therapy Association's training on vestibular rehab, and I've been doing that the last 10 years. And so with that, I tend to see some concussion patients, or quite a few concussion patients. Also been able to present as a presenter and provider with the Save the Brain program that we have here in Kalispell. And just a program that works with concussion patients of all ages. Also trained through Impact Systems as a trained physical therapist, gone through their online training. And just recently in this last year, I did a 40-hour training on concussion management through Complete Concussion Management Incorporated. It's a Canadian company. Really learned some great stuff. That's definitely a website I'm going to direct you to, just because they stay up to date on the latest research and information. I've really been impressed with that program, and I learned a lot. So this is kind of the outline of my talk tonight, just the myths of concussion and how I can hopefully dispel some of those myths. So the first one that I've seen a lot is concussions happen only from hits to the head. We'll talk about the mechanism of concussion. Also, if you have a concussion, you just need to rest. That's one of the big ones. The research in the last few years has really changed on what we recommend as far as rest and activity. Obviously, I'm going to talk a lot about treatment tonight, and as a PT, I do various kinds of treatment with concussion, but there are still people out there that think just let it rest and there's not much you can do about it. Another myth is that recovery of symptoms equals full recovery and return to play. I'll talk a little bit about that later as far as how we're getting athletes back, and it's not just, oh, I don't have any symptoms anymore, I'm ready to play. There are some things we need to go through with those athletes. Another myth is that special helmets and mouth guards can prevent concussion. We'll talk a bit about that, and that The last one I'll talk a bit about is that concussions cause long-term damage. So I'm going to spend quite a bit of time just talking about the mechanism of concussion, some of the physiology. I think this is where a lot of the misunderstanding of concussion occurs, in that for a long time we thought one thing about the mechanism, and really the research in the last few years has changed as to really what's behind the cause of the symptoms that athletes are experiencing. So the Berlin Consensus Statement on Concussion in Sport that came out in 2016, the concussion consensus statement usually occurs every 4 years. There's an international concussion conference, and they talk about management, definitions, and concussion. So concussion definition is a traumatic brain injury occurring as a result of direct or indirect force transmitted to the head, causing metabolic and functional changes. So that's already one of the myths we talked about, is that you have to get hit in the head, and really you can get hit in the body and create that enough force to cause a concussion. But the big thing is that it doesn't cause prolonged damage. It's temporary dysfunction rather than a structural injury. So you're not creating a structural injury to the outer part of the brain like some people might suspect. It's a temporary dysfunction that occurs. So it's also known as a mild TBI, a mild traumatic brain injury. The word mild doesn't mean that the symptoms are mild necessarily. It's just the severity of the injury means there's no structural brain damage. So moderate or severe TBI, usually you're going to see like a subdural hematoma or something that's going to show up on imaging. So with a concussion, the brain undergoes acceleration. So the fluid waves are created in the brain and cause the axons within the inner part of the brain to stretch. And this injury occurs deep inside the brain as a result of quick stretching of axons and a chemical response that occurs. So as you see in this image here, initially it was thought that the brain kind of bounced back and forth in the skull, and you'd bruise the front and back of the brain, and that's where the injury was occurring. But as you can see in that image, it's actually kind of a fluid wave that occurs in the brain. The brain is more like a gelatinous type substance. I was actually going to make a Jello mold for my live presentation I was going to do in March, but didn't get to do that because of the coronavirus. But that Jello-like substance within the brain, or the way the brain moves, creates that stretching of the axons inside. So like I said, the axon is a part of the brain that transfers information. So it makes the axons fire rapidly when you get that quick acceleration in the head. So that creates a chemical response. You get an outflowing of potassium and an inflow of calcium. And I'm not going to get too much more scientific on that, but that chemical reaction can disrupt or go along with a disruption in cerebral blood flow. And so there's actually an energy deficit in the brain. And that starts initially and then even worsens over the next few hours and next few days. You get even more of a deficit, and that peak low is actually at about 5 days after injury. And then for that energy deficit in the brain to kind of return to normal, it actually takes up to 30 days to fully recover, and that's an average. So during this time when you've got that energy deficit, the brain is highly susceptible to a further injury, and that's where we're talking about taking athletes out, and we suspect that concussion right away because they're really at a risk for another injury. You might have heard of second impact syndrome, where athletes are, experience severe symptoms and possibly even death. That's because that energy deficit, if you get another blow and you lose more of that, the chemical responses that are needed for energy in the brain, you're susceptible to that swelling inside too.
We have a question regarding that. We got a question from a coach asking, what's the most important thing for a coach to watch for in a player?
Okay, we'll go over that in just a bit as far as talking about symptoms. I'll talk about kind of the initial thing you might want to look for when I talk a little bit more about symptoms in just a little bit. So So it takes about an average about 96 Gs of force to produce concussion, the force transmitted into the brain. So pretty heavy load to create a concussion. It's that quick impact, quick acceleration, and energy response in the brain. So like I said, you might see a rapid response, like the coach asked about symptoms, like you might notice that right away. And there might be a delayed symptom presentation. That's where sometimes it gets tricky, that you might not see those responses right away. But as the athlete goes along, they start noticing more and more symptoms. Sometimes people have come to me and said, I really didn't have much that day, and then the next day, man, I got hit. And that's as that chemical response starts occurring within the brain, you're getting more and more symptoms. And like I said before, the concussion isn't going to show up on a CT or MRI. So there's negative neuroimaging reflecting a functional rather than a structural injury. So sometimes people say, oh, it's a bruise on the brain, like they think it's going to show up on a CT or MRI, and it really won't. And I think there's a lot of unnecessary tests that are sometimes done as people are looking for that injury, and it's really not going to show up. If you have a more severe traumatic brain injury is when you're going to find something on a CT or MRI. And this is a big thing too, is I think people suspect that you need to have a loss of consciousness. 90% of concussions, there is no loss of consciousness. So, and also the loss of consciousness doesn't reflect the severity of the injury at times. So someone that maybe didn't get knocked out might have more symptoms lasting longer than someone that did lose consciousness. So, and then the last thing is that the symptoms are gradually improving over time. Typically, you're not going to see someone dramatically improve from one day to the next. So like coach asked, our athletic director asked, signs and symptoms. What do I look for as my athlete is on the field or coming off the field? And if you suspect one or more of these symptoms that warrants removal from play and further assessment for concussion on the sideline or even after the game. But if there's any suspicion, you know, you've probably all heard that when in doubt, sit it out. And that's because if there's any one or more of these signs or symptoms, we really want to be checking for concussion. So a big thing, so the signs are kind of what coach would look for. If you're seeing your athlete not being able to recall events like right before the hit, or they're looking dazed or stunned, you might see them kind of wandering a little bit, like not coming back to the huddle or not coming back to the play as fast as they should. Or you're yelling out a play and they're really not tracking with you. That's a pretty good sign. Sometimes a little harder in high school athletes to tell, or you might see them moving clumsily or not answering question. If you did observe that loss of consciousness, you might see them look dazed as they went down, or you see kind of that arm stiffening or the lack of movement for a few seconds even. That might be a good clue that there was a loss of consciousness. Or changes in mood or behavior. And then the athlete might tell you, man, I've got a headache, or feeling pressure in the head, or nausea and vomiting is actually one of the first early symptoms of concussion. And then sometimes you'll see that headache come a little bit after, and that sluggish feeling or fogginess, confusion or concentration, just say, I don't really feel right, something feels off, or things look kind of blurry. So I think kind of you have to be really watching and listening for that. And I think a lot of concussions talks really kind of look at signs and symptoms. There's checklists that a lot of the schools get to. So, you know, keep an eye out for some of those. There's lots of information. I'll share some websites at the end. But I think having a really good, like, little card in your pocket or something, just to kind of go through that every once in a while and say, what am I really looking for here? But like I said, it's important if you suspect anything, we don't want that second impact, and I'll talk about that in a second. Before that, the red flags, like why would I send somebody to the ER if it's like, this might be a concussion, but now I'm seeing things that, like, okay, this might be something more. So if that headache that they're experiencing starts just worsening and it's unrelenting, or you're having trouble kind of keeping them awake, or they're losing consciousness after that initial hit, that's definitely a red flag to get them to urgent care quick, or ER. Seizures, that's kind of an obvious one that people get a little more concerned about, but some of that weakness, numbness or tingling in the arms and legs, severe imbalance, so not just kind of stumbling, but they're falling over, they can't maintain their standing balance, like that's a pretty big warning sign. Changes in speech or loss of vision, I'm losing vision in one eye. A really obvious one would be like fluid leaking from the ears, that I think would spur most of you to send someone to the ER. But 2 black eyes might show bleeding around the face, persistent vomiting. So like I said before, that nausea and vomiting might occur initially, but if it's like they keep vomiting over and over, that's a bigger sign. And then memory loss that's occurring more than 30 minutes before the injury. Okay, so we've looked at concussion and we suspected it. Like, how do we start managing it immediately? I'll reiterate again that removal from play. The big thing is that we find that we've had a few people like, oh, there's maybe a suspect. We kept them in the game. They started reporting more headache. We took them out. Even just that extra quarter they might have played can delay their recovery and their response. So you want to make sure if you're suspecting it, like it's not worth it to send them back in for more play. You're just delaying that recovery even farther, and they're going to have more symptoms too. So, and then really the thing I really key in on is getting people in early for an assessment by someone trained in concussion management. You know, it can speed up that recovery time. They're getting more information, getting treatment right away, getting in the proper referral sources like a PT or their athletic trainer. Ideally, in the first 24 to 48 hours, I want athletes getting information, assessment for concussion, so they're getting on the right track, getting their return to school, return to activity kind of managed a little bit better. So kind of subacute, like looking at the stages of concussion management. Well, and I'm going to go through each of these individually. A period of brief rest. Understand I've highlighted that, and I'll talk about that in a minute. People are still prescribing loads of rest for post-concussive athletes, and the research is kind of changing on that. And the next thing is huge, is that education, reassurance, addressing any of the psychological comorbidities that might be occurring. The more athletes know right away, the better their concussion is managed. And I'll show you some research in a second on that. Looking at some exercise therapies, vestibular and vision rehab, neck rehab, diet, sleep hygiene. These are all areas that when I have an athlete coming in, I'm trying to address all these different things. And I know other concussion practitioners and athletic trainers, these are kind of the highlights of what we're looking at once we know there's a concussion diagnosis too. So like I said before, rest. Symptom limited physical and cognitive rest is what's being recommended in the research now. So 2 to 3 days is kind of the max of what we want people kind of really laying low. But even in that, I suggest doing some light walk. If your symptoms aren't increasing, I want people doing a little bit of physical load or cognitive load, like, you know, if you're okay cooking dinner, it doesn't increase your symptoms, you're okay to do that. You don't just need to go lie down and sleep in a dark room in those first couple days. So light physical activity, provided that it doesn't increase symptoms or bring on cognitive or physical signs or symptoms. I think that's the big thing, is like keeping track of where those symptoms are at, and when I start some of that light activity, if it starts increasing in that first 2 to 3 days, we want to rest a little bit. But like I said below, it's like, don't lie in a dark room. Even in the early stages of recovery, during the day, you should at least be up and sitting and do some light activity. So the literature in the last few years suggests that early low intensity physical activity in the acute phase following a concussion may decrease the time needed for symptom resolution compared to strict rest. So we're really trying to change the tide on that of not going back to, sport right away, but also not sitting and doing nothing for a few days or beyond a couple days. And the education, reassurance, and addressing psychological comorbidities. So we do know that pre-existing anxiety and depression, and if someone is reporting high symptom severity score in the acute stage of concussion, this might suggest that they're going to have a little bit longer recovery. So if we can kind of see, like, there's a symptom chart that we look at of what patients are reporting. If we see that those numbers are really high, we want to address, like, are you having some fear or anxiety about your injury? Here's what concussion is. That's why I go over that section. I started out with the anatomy and the physiology of what's really happening. This isn't a long-term damage to your brain. I spend a lot of time on education, reassurance that, hey, this will get better. We're going to get you back to your activity, back to school. And athletes with a history of mental health diagnosis or migraine, either themselves or a family history of migraine, might have a higher risk of symptoms lasting longer than a month. So that kind of goes into some of those post-concussive syndromes. At times you can see that. So we want to make sure we're kind of stepping in early and helping some of those athletes along, getting the appropriate care. And a significant predictor of prolonged recovery, like I said, is inadequate patient education following injury. This research study in 2018, they looked at information given to athletes after discharge from the ER. And if they didn't receive any information, it significantly predicted persistent concussion symptoms, and they reported 2.3 times more symptoms as well. So sometimes just like a little bit of basic information or sending the athlete to someone who can spend the time educating them is a huge component to concussion management. So I'm obviously stressing this a lot. This is one of my first points because I think it's very important. And exercise, this is the big push in the research. This group by the University of Buffalo, Letty, you'll see quite a few research studies from his group looking at sub-symptom threshold aerobic exercise, even within the first week after a sport-related concussion, that can help speed recovery. So it's not necessarily aerobic exercise sending them back into sport, back into practice, but getting them moving right away within that sub-symptom. So people say, what's sub-symptom mean? Basically, getting the activity level up, getting the heart rate up where it's not increasing that headache. So, my headache's at a 1 to 2 out of 10. Like, I want to keep it kind of within that threshold. And that's where the subsymptom threshold testing. So Letty's group developed the Buffalo concussion treadmill test, and that's right now kind of considered one of the gold standard tests. That's a test that I do in clinic, looking at, what's that threshold when we increase that heart rate, when we look at that aerobic exercise, what is that heart rate tolerance? And then that can help develop their exercise threshold for the next few weeks too. And we can even use that as a measurable tool to look at how's that recovery going, and two, how can we guide their exercise in a safe manner, not just like send them back on the treadmill. It's like, okay, here's your threshold of your heart rate where you can safely exercise. So with the treadmill test, it's basically a walking test. We're measuring heart rate and then increasing incline, and as the person is walking fast, just upping that incline every minute and looking at that heart rate response. During that whole time, I'm looking at their perceived exertion, like how hard they feel like they're working, and also so I'm asking, like, okay, any increase in symptoms, and we start seeing that symptom increase. We kind of look at where their heart rate's at, and we take a percentage, 60 to 80% of that range at that max is where I'm going to get them exercising. Like I said, they're pushing that in the 2019 study. They're saying even within the first week, getting people on the treadmill and starting to test that. And even in younger athletes, that's even shown to actually help them even more. And I want to emphasize that doesn't mean return to sport for exercise. That means maybe 20 minutes on the stationary bike or lightweight or treadmill, something where they're not at a risk for hitting their head or impacting with another player, individual. So I had a guy, he wanted to get back on his mountain bike, and I said, nah, let's stick to stationary bike, see how you do with that first. That risk of injury is what we want to avoid. So this is a vestibular therapy. This is the area I like to talk about. It's one of my specialties. People often ask, what does that even mean? But the vestibular system is located in our inner ear, and it's our internal gyroscope that tells our brain how our head is moving, how fast our head is moving, the direction of head movement, the pull of gravity on head movement. Our inner ear is actually registering a lot of that, coordinating with our vision and our balance responses. So it's detecting that motion, helping with stabilizing vision and coordination. And so the vestibular system, the research shows that possibly up to 60% of young athletes have some sort of influence on their vestibular system or vestibular symptoms after concussion. So the primary symptoms you might see are vertigo, that spinning sensation. When I change my head position or I lie down, I feel myself spin or the environment spin. Dizziness or lightheadedness. Gaze instability. So that means difficulty keeping their eyes focused while they're moving their head. So I'm trying to look at a target and things are kind of shifting on me with that head movement. That might indicate a vestibular issue, and imbalance or falls. So this is an area, like I said, I've spent a lot of time working with, and it's a huge part of post-concussive recovery because it integrates with some of the other symptoms I'll talk about in just a bit. But people say, well, how do you treat that? It's kind of a variety of things. If I suspect that there's a mechanical issue within that vestibular apparatus, there's treatments for what's called BPPV, or benign paroxysmal positional vertigo. That's when the mechanical aspect of that inner ear has been interfered with. If you've ever heard someone say, my rocks were loose in my inner ear, they might have had BPPV. So with a blow to the head or a concussive force, you can have that condition occur. So in the picture, if you can see me up top, there's infrared camera goggle system that I use that helps with diagnostics. So we can't look into the inner ear and see the mechanical problem, but we look at reflexive responses that occur at the eye because of a vestibular issue. So there's maneuvers that you can go through that can sometimes treat that cause of positional vertigo, that spinning sensation. But also in one of the other photos, Dylan here is doing an exercise where she's working on that gaze instability. So head movement with visual tracking and integrating that vestibular input. And this other picture is a Biodex balance system. So the person is working on challenging their balance a bit to integrate coordination with the vestibular system. So we're looking at all those different things, addressing the visual and net components that I'll talk about in just a second. So vision therapy, you might hear people say, oh, I had to go to vision therapy after my concussion. Sometimes that integrates with some of the things I do with vestibular rehab. There are professionals that they kind of work specifically with vision therapy. So it's not just an optometrist, but actually sometimes occupational therapists or athletic trainers or PTs will work the visual component of concussion rehab. So at least 50% of athletes might experience eye movement problems, difficulty with focusing or scanning. So you might hear somebody say, like, I just feel like things are kind of out of focus or blurred. If I'm trying to read, things aren't staying in focus or kind of jumping. This might be because of a visual component to their injury. But it's not the visual acuity. It's not like you're losing your 20/20 vision. It's more a problem with the eyes working together, working on tracking the information sent from the eye to the brain and vice versa. There's a delay there at times. So like I said, it might be using the screen, scrolling on their phone, or trying to read at school, like just trouble tracking. So this might be an athlete that needs some advanced vision therapy. So the goal isn't to strengthen the eye muscles. I think that's kind of an old way of thinking of like, okay, we're training to get those muscles in the eye stronger. It's more about getting that control and command with the brain's responses with the vestibular system. And so one of the tests I use is called the VOMS, vestibular oculomotor screening. It's basically a test that can help with diagnosing concussion, but can also be helpful for differentiating problems and guiding treatment. And then also neck rehab. This is one of the most often overlooked sources of symptoms in concussion is the neck, the cervical region. More and more studies are showing that cervical injury and concussion are concurrent. So like I talked about before, concussion needs 70 to 120 Gs. I said the average of 96 to occur. So you need that much force to create a concussion, but cervical strain can occur at 4.5 Gs. So if you have enough force to create a concussion, you've probably likely created some sort of injury to the neck. This person might need some hands-on therapy or different exercises, working neck, coordinating with vision and balance. And sometimes I'll do some neck rehab even if the person isn't describing neck pain, because we know that the eyes, the vestibular system, have reflexive coordination with the neck. And so I've treated the neck and gotten rid of some of their dizziness or headache even when they didn't feel like they were receiving any neck pain or information. So a combination of neck and vestibular therapy decreased time to medical clearance to return to sport in youth and young adults with persistent symptoms of dizziness, neck pain, or headache following sport-related concussion. So coordinating some of those rehabs together can be really helpful. I think we have another question. Maybe pre-participation screening, do I do that? I'm working on it. I haven't done a lot of kind of the baseline testing. I'm hoping to do a bit more of that with some of the local athletes. I know the hospital here also does some baseline testing. There are some things that you can look at with athletes, and I'll go into a little bit. Impact, actually, you can buy the neurocognitive testing online on your own. Just take your own impact test. I do recommend people get a little education and guidance if they're going to do that, but that is available. But that is something, as I'm seeing more athletes now, I'm hoping to do a little bit more baseline testing with them. And there's several different resources I'll talk about in just a minute. This is another thing that kind of gets overlooked that I've started paying attention to quite a bit more is actually diet after concussion. Some of the latest research shows that there's possibly a connection between the inflammatory process that occurs in the brain and even what happens in our gut. So even a systemic inflammatory response that occurs post-concussively. And so the theory is that addressing that diet component can really help improve the concussive symptoms. So one of the things I really talk about is kind of avoiding the processed foods, sugars, kind of keeping to a lower carb diet, avoiding the allergenic foods. So some research suggests even going to a gluten-free diet for the first few weeks after concussion can be helpful for reducing symptoms. Looking at more pasture-raised organic meats, fish and chicken, avoiding those red meats for a little while. Looking at healthy fats, really huge connections that have been shown in the research to omega-3s and healthy fats being kind of neuroprotective as the aging athlete advances along, but also post-concussively, they're looking more and more in the research as to whether there is some neuroprotective responses with eating some of those omega-3s and healthy fats. So I try to spend a little bit of time with my athletes going over diet and the importance of thinking about that recovery. Also sleep habits. That's my little educational spiel I do in my first few visits is how are you sleeping and looking at, okay, how can we improve that? The big thing is avoiding the naps throughout the day. When you have that fatigue occurring in the first week after concussion, that tendency is to want to like, I want to go lay down and sleep. I'm taking a 2-hour nap after I leave school early. We want to try to get people into their regular sleep cycle as much as we can. I'm not saying you can't take breaks. I'm not saying you can't take rest. Within that first week, a little bit more rest, but you know, not just spending the whole day in bed. So I really try to get my athletes avoiding those big 2-hour naps in the afternoon. Avoiding caffeine, nicotine, vigorous exercise around bedtime, avoiding alcohol. Hopefully our high school athletes are doing that, but our older athletes, like avoiding that alcohol. Sometimes I've had athletes that, oh, I can't get to sleep, so I'm going to have a drink before bed, and really you get that short-term sedative effect possibly, but sometimes it'll spike back up, so you wake up at 2 in the morning and you can't get back to sleep. And getting that regular exercise is also important. Reducing our screen time before bed. I usually say at least an hour before bed, get off your phone, get off your TV. You know, if you want to read a little bit, listen to some music, that's okay, but really reducing that screen input right before bed. Making the room comfortable, that consistent sleep and wake time. Even if you're not going to school full time or going to work full time or your regular time, like even trying to get up around the same time and go to bed the same time as you were, because your brain has been accustomed to that sleep wake time. So it wants to do what it's used to doing. So trying to keep that sleep wake time similar to what you've typically done, or can keep it consistent throughout the few weeks as you recover. And one thing I want to touch on that was asked by me before I made this presentation, but do we need to wake athletes up every few hours after concussion? The latest information that I've read suggests that we don't need to necessarily be doing that. They do suggest not letting athletes go to bed within the first 2 to 3 hours of that suspected injury, just so you can kind of monitor for any of those red flag symptoms. But it's okay, you know, in the first day or so to maybe check on the person, make sure they're doing okay, but you don't have to go in there and wake them up and make sure they're not falling asleep. They need to be actually getting some rest in those first few days. So that's something I try to touch on, is that information has changed in the last few years of that fear of somebody might not wake up in the night. Is if we've observed them for a prolonged period of time prior to bedtime, it's okay to let them rest. So what can help in return to activity decision? So this is where the question I was asked about preseason testing or baseline testing, because we want to have that information of what is the person's baseline. Some people have some headaches, some vision problems, some balance problem before their season even starts, before they've had an injury. So we want to know what is their norm, and you're not going to know that unless you've done some form of preseason or baseline testing. So that really helps with that return to activity decision if we know we've gotten them to their baseline. So we can't just rely on symptom improvement. Like we talked about earlier, is it could take up to 30 days really for that physiologic improvement to occur. The person might feel better in that first 7 to 10 days, but it doesn't mean they fully recovered. So we want to know kind of where that baseline is at, and that can help make that return to play decision a lot easier. And like I said, this research by Taylor in 2018, while it was reported that self-reported symptoms diminish after a few days or weeks, it was found that objective deficits can persist much longer than this. Looking at preseason testing, there are issues with the single test. People say, oh, I did the impact test. But if that's all you've done, there are some limitations there. Computer tests really aren't enough just by themselves. There's a lot of confusion around, well, baseline testing doesn't really work, the impact doesn't really work. Well, the research kind of suggests just by itself that might not be the best thing, but a good baseline should have retest reliability involve a battery of tests. So looking at balance, reaction time, cognitive ability, memory, visual processing, their exercise capacity. So, and these tests don't have to be super complicated. Some of the balance tests take about, a minute to administer. Reaction time testing you can do pretty quickly, so you can incorporate a few other things, and also doing a preseason symptom checklist and asking, do you have daily headaches already? Do you have vision problems? Are these things maybe we should be looking at preseason and getting them addressed to prevent injury? So I think that preseason testing is really important, and that's something even probably in this last year I want more people to be doing, more athletes to be doing. So looking at return to learn, work, and play as we progress along, what are the steps? So in this diagram, if you can see, these are stages, not days to recovery. So it goes from 1 to 10, and it's not suggesting that 24 hours in between these is 10 days. This 10-step process could take a month or so in some athletes, hopefully not that long, but at times it will, to get that physiologic recovery. So in the first stage, in that first few days, that symptom limited activity, the person's at home doing some rest, some light activity. And then in the second stage, cognitive activity, might be doing some reading, just basic tasks, and seeing how they do, how symptoms respond. And then if the athlete is doing okay, we can send them into a half day of school and work with restrictions. So they're getting help with their homework. It's probably staying off the computer testing, maybe getting notes sent to them. So looking at the next stage is looking into going into a full day, how the person tolerates it, and see how they're getting through the full day of school. That's when we can start going into more physical activity, and that's where we might do the Buffalo concussion treadmill test and see what is that threshold, and then returning them into that return to play guideline into sport specific activity with some restriction, into non-contact drills. And then on here on the screen, that's Chicago Blackhawks test. It's kind of for higher level athletes, but doing some high level exertion testing or looking at their baseline tests, kind of pushing into more exertion and before they go into full practice and then gameplay. So 24 hours in between all these stages. If they start feeling symptoms, you have to send them back to that lower stage. So in order to return to play, you need to be symptom-free at rest, with cognitive exertion, with physical exertion, and not using recovery meds. So if you're taking meds to address the headache component, to return to play, you should be off those medications. And back to normal on the balance testing, the VOM screening, and some of the neurocognitive testing, so that impact test. We want to go through all those things and have normal responses before we're sending the athlete back to play. So this is a big one I get. I figure I'll answer the question before I might get in the comments, but do helmets, mouth guards, or soccer headgear prevent concussion? And really the research is saying basically no. A helmet, those fancy helmets are really good at preventing a skull fracture, but like you saw in that graphic and as we started out, is that acceleration, the helmet's not going to stop that from occurring in the brain. So it prevents that impact, the skull fracture, which can prevent further injury, but it's not going to prevent concussion. So the extra money that people are spending, I'd say keep your money and work on things to avoid the contact that might occur, or the research in this was 2019 study, supports that protective gear was not a preventative measure for concussion. So it can create a sense of false confidence, oftentimes like, oh, I've got my fancy helmet, I can go in there and hit head to head. It really isn't going to prevent concussion. In fact, you're putting yourself at more risk if you're thinking that's going to occur. So another one I get is soccer heading. Are the soccer headgear appropriate? The research doesn't really support that can prevent concussion, because it looks like with soccer heading, you're getting about 20 Gs, but it takes 96 Gs to create a concussion. So it's more the player-to-player impact is where in soccer that concussion occurs. So we might want to teach better technique rather than trying to rely on headgear. So just briefly on post-concussion symptom, this could be a whole 2-hour talk, so I'm not going to spend a ton of time, but people often ask, what if symptoms are lasting longer? So if an adult more than 2 weeks, and in younger athletes, if symptoms are longer than 30 days, we're looking more into that. What's the cause of post-concussive syndrome? Why is this taking a little bit longer? But I still want to reinforce that it doesn't reflect that there's one thing or a pathophysiological entity or ongoing trauma in the brain. It might just be maybe there's something we haven't addressed in their symptoms, or maybe there's changes that have occurred that are kind of increasing that chance of longer lasting symptoms, like we talked about earlier, is that education component too. But there are certain things that in the research they've looked at causes of these prolonged symptoms. So blood flow issues, so that initial deficit with blood flow, sometimes it persists a bit longer. But that is still easily addressed at times with just an exercise program, getting that increased circulation, addressing the heart rate changes, and kind of pushing the system a bit to want to improve back to their baseline. Hormonal responses, some of the research recently has looked at the pituitary system and maybe how it can be influenced by concussive responses. The vision and vestibular, if there's visual tracking deficits, a person's continuing to try to read, but we haven't addressed some of those deficits, the symptoms might persist as they try to get back into school and activity. Addressing the neck and the psychological component is also important with these prolonged symptoms. So the risks for having these symptoms, so a history of previous concussion can make you more apt to having prolonged symptoms, multiple injuries, pre-existing mental health conditions, added stress, and younger children and adolescents take a little bit longer to recover. Improper management. So either we're sending the person back too soon, or they're not doing enough activity early on. So what's the risk of a repeat injury after concussion? People say, oh, if I go back, I'm going to get more and more and more. And the research is really mixed, and we're still trying to learn what are some of those risks after concussion. But really the thing I've read the most on is that it's not the number of concussions, it's how close together they are. So if I'm going back too soon and I sustain another injury, that sets back that energy deficit, it sets back the symptoms. And then if I get another injury on top of that too, you're just compounding that effect. And so that's kind of what I've seen with athletes, is that they've sustained an injury back to back, and now they're looking at that post-concussive syndrome. So that's where that education component and not sending athletes back before they're ready, I think that's where we're going to decrease that risk of prolonged symptoms and repeat injuries. So looking back in summary, I know I've talked a lot about kind of a variety of things. Hopefully you've learned some things and dispelled some of the myths. So concussions do not happen only from hits to the head. You can have impact anywhere on the body, but if you have enough force, that 96 average Gs transmitted into the brain. That's where you're going to see that concussive injury. If you have a concussion, you just need to rest for a short time and then get moving. That exercise piece, get people going within that subsymptom threshold. There is treatment for concussion. Obviously, I've spent quite a bit of time showing you there's things we can do and address with concussion. Recovery of symptoms does not equal full recovery. So my symptoms are gone does not mean I'm better and I'm ready to go play. I need to look at full recovery physiologically. Can I withstand that exertion load and not increase that if I'm going to go back to play? Special helmets and mouth guards do not prevent concussion, and concussions do not typically cause long-term damage. They're not a structural injury to the brain in a way where you've damaged the brain and that part of the brain is not coming back. A concussion is a temporary injury. There's things you can do to help the recovery process along and decrease those symptoms. So just a few resources if you want to take a screenshot of this. This can be a few helpful places to look. If you're located in the Kalispell area, the Save the Brain Concussion Program through the Summit, the Department of Physical Medicine and Rehab, they have a whole concussion physician group that looks at testing for concussion and management of some of the medications. And so that's a really great program I will send people to if they haven't had a medical management prior to seeing me. CCMI is where I obtained quite a bit of my information. They stay really up to date on a lot of the research, so completeconcussions.com is a great place to go. They have an app that you can track concussion symptoms. They also have a good YouTube channel with a variety of podcasts. You can follow them on Instagram. Just a really great resource. They really spend a lot of time looking at what's new and what's relevant and what's good information for not just practitioners, but athletes and their parents. The University of Pittsburgh Medical Center Concussion Center, Rethink Concussions. They're also one of the top research groups in the university setting that looks at concussion and injury. The VOMS test that I mentioned earlier was developed at the Pittsburgh Medical Center, one of the really great testing tools that we have. And I had mentioned before, you can actually go on the Impact website and buy a baseline test that you can take at home. It's $20. So if I've actually thought about doing my own, just having a baseline test if I'm out there mountain biking and recreating where I have the possibility of concussion, that might help just kind of with some of the objective measures as far as return to activity. This is my contact information if you have more questions, if you had things that didn't get answered tonight or you want to contact me about any treatment. I'm at the Ortho Rehab Evergreen Clinic in Kalispell. So if you're Kalispell local, right by Edgerton School off Whitefish Stage, my email. So if you want to take a screenshot of that information, give me a call or an email sometime if you just want to talk or have questions. But I think we'll open it up. Tyler has a few more questions that have come in, I think, as I've talked, and hopefully you found some good information, dispelled some myths, and hopefully we're getting athletes back safely and addressing concussion appropriately. So what's another question?
All right, we had a question from somebody asking about circling back to the diet recommendations. Mm-hmm. Whether or not there was some specific diet recommendations, and also if you had some handouts.
I do actually have a whole handout. I was going to include that in my slides, but it got a little busy looking. So if you actually want to shoot me an email, I can send you that handout. That came from Complete Concussion Management. I think they do have some of that on their website, but I'm happy to share what I have started handing out to athletes. I just actually, with my downtime during coronavirus, I've updated some of my handouts. So shoot me an email. But yeah, like I said, that basically your healthier diet, avoiding the processed foods, blueberries, chicken and fish, nuts and seeds, avocado, olive oil, kind of that healthier Mediterranean diet. Actually, the Mediterranean diet is one in the research that's kind of the recommended diet to follow too.
We have another one coming in asking if a athlete has a history of concussion, one or more in the previous year. Are they more prone to sustaining future concussions?
Okay, so the risk of future concussion, if you've had one that's within the year, it kind of depends on their symptom recovery and their physiologic recovery. So if they're still reporting symptoms, or if they're still having symptom increase with exercise activity or cognitive load, yes, they're likely at risk for another concussion still within that time. So you want to address maybe some of the ongoing symptoms, but the research is a bit mixed of like how soon is too soon. That's why I didn't include as much of that in this talk, just because it's still a little bit debated about like what is that increased risk. I think watching some of the movies like Concussion and some of the NFL stuff on CTE, there's a ton of misinformation out there on that prolonged risk, and some of the stuff I've read recently has kind of made me question like, okay, how much do we have to look at pulling athletes out? If they're not having symptoms and they're back to exercise tolerance, I think they're doing okay. So, any more questions or anything coming in?
Yeah, we had a question. If I'm a coach and I suspect an athlete has a concussion, want to get them in for treatment to a therapist, what are the steps I would take to get them into therapy?
A lot of times I just say, give us a call and we can kind of help determine, are they appropriate to come into physical therapy or occupational therapy, or do they need some medical management? Sometimes I feel comfortable if they've had some testing done or their athletic trainer sends them in. I'm happy to start doing some testing and treatment if I think there's maybe some question as to the diagnosis, or there needs to be a little bit more medical management and referrals to other sources. In the Kalispell area, I refer them to the concussion clinic, or some people will go to Dr. Bowles at the community medical center to have their kind of management done. But yeah, I'm happy to kind of have people call in, and then we can kind of decide from there, are they appropriate to start a PT setting or with their athletic trainer. So hopefully that answers that. Any other questions coming in? Okay.
We didn't have it on YouTube for people.
Yeah, so we are going to have this webcast up on YouTube. So if you want to check it out later, I don't have the YouTube address available at this time, but I think it's the Ortho Rehab YouTube channel. If you just search that in YouTube, that'll be up there fairly soon, so you can rewatch or share it with someone. I'm hoping at times people maybe actually have a few more questions when they see stuff like this, and kind of do a little bit of their own research, or come and talk to me, or give me a call or email. But the more we're talking about how best to manage concussions, I think our athletes are going to do better and decrease that risk of further injury.